7-year-old Leo had finally found a rhythm that worked. Diagnosed with autism spectrum disorder at age 3, his progress relied entirely on the fragile trust he built with his primary behavioral therapist. Then, the clinic's ownership changed hands. Within 6 months, Leo was assigned 14 different therapists. The carefully structured routines that anchored his world dissolved into chaos, replaced by a revolving door of exhausted strangers. His regressions were immediate, profound, and entirely preventable. This sudden collapse of care is not a localized tragedy or an unavoidable medical misfortune. It is the deliberate byproduct of a highly lucrative business model sweeping across the United States. Families desperately seeking stability for their neurodivergent children are finding themselves trapped inside a rapidly consolidating industry. The waiting rooms look the same, but the hidden architecture governing their children's treatment has been fundamentally rewired to serve distant financial interests. To comprehend the scale of this disruption, we must examine the mechanics of applied behavior analysis, commonly known as ABA therapy. Regarded by many medical professionals as the gold standard for treating autism, this intervention requires intense, consistent one-on-one interaction. Success is measured in micro-milestones over months and years, demanding a profound clinical commitment. It is a slow, deeply human process that resists easy automation or rapid acceleration. Historically, the landscape of autism care reflected this localized necessity. Clinics were predominantly founded by specialized practitioners and behavior analysts. These were small, community-focused practices where clinical outcomes dictated the daily schedule, not quarterly revenue targets. Therapists had the autonomy to design highly individualized treatment plans, adjusting their hours and methods to meet the specific evolving needs of each child without the looming shadow of corporate productivity quotas. That fragmented, highly profitable landscape presented an irresistible target for Wall Street investors. Enter the roll-up strategy. Private equity firms deploy massive pools of capital to buy dozens of these small, independent clinics, aggressively merging them into massive, standardized regional chains. By acquiring these practices in rapid succession, the investment firms aim to dominate local markets, transforming a patchwork of independent healthcare providers into a monolithic corporate asset. The financial logic driving this consolidation relies on artificially inflating the newly formed company's valuation. Investors focus obsessively on a metric known as EBITDA, or earnings before interest, taxes, depreciation, and amortization. By centralizing back-office operations, standardizing clinical protocols, and scaling up patient intake, the private equity sponsors create the illusion of a highly efficient, rapidly growing enterprise. It is a mathematical exercise designed to maximize the sticker price for the next buyer. Inside the newly acquired clinics, the atmosphere shifts with whiplash-inducing speed. Clinical directors who once prioritized patient well-being are frequently replaced by regional managers armed with complex financial dashboards. The daily operational focus pivots from clinical efficacy to metric optimization. Therapists are suddenly subjected to rigid scheduling algorithms, forced to navigate an environment where their professional value is calculated almost entirely by their ability to generate continuous revenue. The new corporate mandate is glaringly simple: maximize billable hours at all costs. Practitioners who previously spent careful, unbilled time preparing individualized session plans or consulting with distressed parents are pushed to take on unsustainable back-to-back caseloads. The breathing room required to deliver compassionate, effective care is systematically eliminated, replaced by a relentless assembly line of scheduled appointments designed to keep the revenue engine running at maximum capacity. This intense pressure inevitably breeds aggressive insurance billing practices. Every available minute of a therapist's day must be monetized. We see internal directives pushing clinics to stretch therapy sessions longer than clinically necessary, or to mandate a minimum number of weekly hours regardless of a child's specific developmental needs. The objective is to capture the highest possible reimbursement rates from insurance providers, transforming therapeutic interventions into maximized billing events. For the children at the center of this financial optimization, the consequences are disastrous. Consistency is the absolute bedrock of effective ABA therapy. Yet the corporate roll-up model treats highly trained therapists as interchangeable cogs in a larger machine. When one practitioner is double-booked or reassigned to meet a scheduling quota, a child is handed off to a stranger, leading to disjointed, ineffective sessions that shatter crucial developmental momentum. The resulting high-pressure environment creates a predictable and devastating crisis on the ground. Clinic staff turnover reaches catastrophic levels, with some private equity-backed chains seeing more than half of their entire workforce quit within a single calendar year. The emotional and physical toll of managing overwhelming caseloads, combined with the moral injury of delivering compromised care, drives passionate professionals out of the industry entirely. Former employees frequently describe a culture defined by relentless burnout and ethical compromise. They speak of being trapped between their professional obligations to vulnerable children and the uncompromising demands of their corporate employers. Many recount agonizing decisions to walk away from patients they deeply cared for simply because they could no longer participate in a system that prioritized aggressive billing metrics over meaningful clinical outcomes. For the private equity sponsors orchestrating these takeovers, skyrocketing therapist burnout is merely an acceptable operational friction. The true objective is never long-term healthcare sustainability. It is the financial exit. The entire architecture of the roll-up is designed to culminate in a massive sale within 3 to 5 years. The initial investors intend to cash out quickly, leaving the consequences of their aggressive restructuring behind. The mechanics of this exit often involve a leveraged buyout by an even larger investment firm. The original private equity group sells the consolidated chain at a premium, walking away with staggering returns. However, to finance this secondary purchase, the new buyers load the clinic network with an immense amount of corporate debt. The healthcare provider is forced to use its own revenue to pay off the massive loans taken out to acquire it. Federal regulators remain largely blind to the systemic dangers of this aggressive consolidation. Because the initial purchases of individual independent clinics often fall below the $119.5 million reporting threshold, these roll-ups frequently evade federal antitrust scrutiny entirely. Private equity firms can quietly devour entire regional networks of autism care without ever triggering a mandatory review by the Federal Trade Commission or the Department of Justice. This glaring regulatory void allows investment firms to operate in the shadows, quietly cornering local healthcare markets. By eliminating independent competition, they create localized monopolies. When the quality of care inevitably plummets under the weight of corporate mandates and high turnover, families are left with absolutely no alternative options. They are forced to endure substandard treatment simply because the private equity firm owns every clinic within a 50-mile radius. Eventually, the massive debt burden loaded onto these consolidated chains catches up with reality. When interest rates rise, or when insurance providers begin to push back against aggressive billing patterns, the financial house of cards begins to sway. The clinics, stripped of their financial reserves and saddled with insurmountable loan payments, find themselves unable to maintain basic operations or retain their severely depleted clinical staff. When the collapse happens, the fallout hits the most vulnerable with brutal suddenness. Across the country, private equity-backed clinics have abruptly shut their doors, sometimes offering families and staff only a few days of notice. Children are abandoned in the middle of crucial developmental windows, their progress halted overnight. Parents are left frantically calling wait lists that stretch for months, watching helplessly as their children lose hard-won developmental ground. This profound devastation within the autism therapy sector is not an isolated anomaly. It is the exact same financial playbook private equity has successfully deployed in nursing homes, emergency room staffing groups, and dental practices across the country. The extraction of wealth follows a meticulously tested pattern. Acquire, consolidate, optimize for billing, load with debt, and exit before the structural integrity of the healthcare provider completely fails. Healthcare economists continually point to a fundamental, irreconcilable incompatibility at the heart of this model. The ruthless, short-term efficiency required to execute a highly profitable 3-year financial flip directly contradicts the long-term, patient-centered nature of chronic behavioral care. You cannot accelerate the neurological development of a child to satisfy the quarterly yield expectations of an institutional investor without fundamentally breaking the system providing that care. We are witnessing the systematic strip mining of the American autism care infrastructure. As billions of dollars are extracted in corporate profits, the foundational support system for a rapidly growing neurodivergent population is being hollowed out from the inside. The clinics that remain are often heavily indebted husks, structurally incapable of providing the deep, consistent therapeutic interventions that defined the industry just a decade ago. Behind every complex, leveraged buyout, every optimized billing cycle, and every staggering corporate dividend, there is a family left scrambling in the dark. They are the ones paying the ultimate hidden price for Wall Street's quiet takeover of behavioral health. They are forced to trade their children's vital developmental futures to subsidize private equity's relentless pursuit of short-term quarterly gains, left holding the broken pieces of a system that was supposed to care.